So let's first of all start with those significance of medication discrepancies in our ESRD patients. So on average, our patients consume anywhere from 5 to 14 meds. Can't we see that on all those lists? Anywhere from 17 to 25 doses per day. When we look at our hemodialysis patients, they have anywhere from 2 to 9 different providers, so that's how many hands are in the pot, right? And 5 to 11 different comorbid conditions, those big problem lists. Now, all of this is going to add into the complex nature of our patients, which is why people say, gosh, you do nephrology, you do dialysis? Oh my goodness, how do you take care of those patients, right? Then we have our ESRD patients who go in and out of the hospital quite frequently, usually on average about twice a year for the majority of our patients. So what happens when they go into the hospital? Things get changed. What causes rehospitalizations the majority of time in ESKD patients? Med issues, okay? So if we're not doing good transitions of care, and I know that's hard to do sometimes in the dialysis units, this is going to become an issue. So when we think about the frequent medication problems that our patients may have, it may be back to all of the complexity of the problems that they have, those frequent hospitalizations, and then, of course, having multiple providers. So when we think about our medication problems being the leading cause of morbidity and mortality in this patient population, and again, this is heightened because of polypharmacy, right? That's all those meds that we just talked about. Again, upwards, up to like 19 a day. So we have to remember all the side effects of drugs anyway, and that we know that's a risk factor as kidney disease progresses. Many medications are removed or eliminated by the kidneys themselves. So again, we have to start thinking about which doses need to be changed, etc. So everybody that's in our dialysis unit does not have the same eGFR. Now, I know some of you may not still calculate that, but there is patients in your unit who has residual renal kidney function. And we want to preserve that as long as possible because that is also linked to morbidity and mortality. Okay, so you may have a patient who has a GFR of 12 and then someone that has a 2. Usually when they get 2 to 3 is when we stop seeing that urination. So again, I pull out my calculator and I calculate on my patients. And remember, we have anywhere from AKI, a patient that's been there 2 months, and some people have been there 20 years. So you want to look at that, and that can help. And if you're a provider, that can help with some of the medication prescriptions that we're going to talk about. Okay, so we have to do a little pharmacokinetic background, and I know we'll all remember this from all of our pharm classes, and we remember absorption, distribution, metabolism, and elimination. So remember, ESRD affects all of these areas in certain medications. So when we think about absorption, many drugs are absorbed in that GI tract, and in our dialysis patients, there's alterations in our GI pH. There's also disturbances depending on what other comorbid conditions they may have. When we think about distribution, many of the drugs are affected by protein binding. So our patients in our dialysis unit, if they're still producing urine, most likely have protein loss. So they have some form of proteinuria up to nephrotic syndrome. So you know that distribution can be affected. Now, liver function can also be affected. So when we think about drug metabolism, remember our patients have all kinds of comorbids, right? So some drugs are eliminated by the kidney and others by the liver. So we want to be able to put those together and understand that some of those alterations happen with those metabolizing enzymes. And then last is that elimination, where there can be that impaired function as our creatinine clearance continues to go less and less. In general, ESRD is under 10 is how we categorize them. When you look up meds in your drug apps, that's what it's going to say. But remember, everybody's different. You got to look at that individual patient. Also, some drugs are dialysable, but not all drugs are. So the other great thing is to have is when I started, so I've been doing this 23 years, we used to have a big list. It was posted on the door. It was like a big poster, so I could go over and see which drugs were dialysable. We now have an app. So if you've not got the Dialysis of Drugs app, you need to look that up because you can't assume everything is, and then that will affect when we tell our patients to take those medications. So continuing in our background here, so we've got uremic toxins. So again, they're uremic coming into treatment. So as a brand new patient, BUN is high, that's the reason they're with us. But what happens all week? The spikes and the plateaus, right? So they're having uremia intermittently every week in between treatments as the toxins build up. And of course, that interferes with metabolism and elimination. And then which modality type are they on? Is it peritoneal dialysis? Is it hemodialysis? Hemodialysis is more rapid, right? We do average 4 hours in a given day. PD is 24 hours, 7 days a week. So that can affect the medications as well. And then we have dosing adjustments. And again, each medication's different. And we start learning them, and we're going to go a bunch today of the main ones that we see, so that can help remind you of those things to pick up on those lists. All right, so then we think about dosing adjustments. So sometimes it's the milligram that needs to be changed. Sometimes it's the frequency inside that day. Instead of being BID, it's Q day. But don't forget, there are some meds, and we'll see these culprits at times coming out of the primary care office, coming out of the ER, when medications need to be 48 hours or 72 hours, and that gets missed when people don't have kidney on the brain. So we've got to be able to pick that up. So when I think about a lengthening interval and a dose reduction, I think of levofloxacin. The loading dose is fine, but then they're supposed to be on a reduced dose, usually anywhere from 250 to 500 every 48 hours, and that is missed all the time in ER. So we don't want to forget about the calculation on individual meds. And then we go back to thinking about all the patients we see, whether it's CKD or ESKD, and going back to that pathophysiology in that kidney. So we have alterations. Again, we may still have some function. Remember, not until we get to 2 to 3 on that GFR do we have a complete loss. So when we think about the structure of the nephron, we go back to the glomerulus. We are going to have lower flow and filtration right inside that glomerulus, but also as we go out into the tubes, the tubular secretion and reabsorption, and as well as the bioactivation and metabolism right there inside that nephron structure. So inappropriate dosing, is it bad? It can be. So they can become toxic, and then of course they can develop adverse effects, or it can just be ineffective. So I think of furosemide. And gosh, how many people have I seen just stop it at the beginning of treatment? We're going to talk about that coming up, so we'll talk about why that's not good. But if you're not on the right dose, most ESKD patients minimally need 80 BID, but I do a lot of 240 BID. If you're seeing a dialysis patient on 40 Q-day, they're wasting that pill is just not doing anything for them. So we have to be respectful of the dosing, but understand what it takes to effectively work at a reduced kidney function. And then we've got our aging population, right? We have so many elderly patients in our dialysis units, and, we all may have a different age bracket in this room, but usually we're calling that above 65 years of age. Everybody in this room, we start getting decline in our creatinine clearance starting in the 50th decade and every 10 years after that. So we're all going to get some senile nephrosclerosis with age. So even if you're seeing patients in your office setting and not in the ESRD setting yet, there is some age decline just in kidney function. Sometimes we get them referred to us too early, by the way. Someone will say, hey, see this person with this creatinine of 1.3 and their calculated GFR is 72 and they're 89 years of age. Thank you for coming to see me today. I don't ever have to see you again, right? Because this is just age related and they're going to be okay. But that primary care saw the GFR and is like, we need to send them to nephrology. And then we also go back to that polypharmacy and understanding all the combines of that. And that can be a major issue with our elderly patients as well. And I realized I didn't change my screen. I'm so sorry for that. I'm managing 2 screens up here, so I apologize. And then we are talking about what about loading doses versus maintenance doses, and you're thinking antibiotics. So many of us know the statute, so we are prophylactically trying to prevent infections, so we always want to cover gram-positive and negative. So our gram-positive coverage typically in our dialysis unit is vancomycin. Our gram-negative options are aminoglycosides, whether you're a GENT unit or a tobramycin unit, or we can use an alternative on a cephalosporin like Fortaz.